Whoa.
Here we go.
Here we go.
Hello, everybody. We're just going to take a minute to let everybody kind of hop on here. Turn your cameras on if you are feeling it.
Yeah, so I can see everyone's face. Hi, Natasha. Hi, Max. I know. So I know everybody. Well, some people.
Sweet. Okay. So we'll give maybe another minute before we fully get started here so everybody can kind of like jump on. Can everybody hear me okay? Yes, thumbs up. Anything? Perfect. Thank you. Okay. So, hello, everybody. Thank you for being here. I'm Taylor. I am a chiropractor and part of the clinical athlete team. I'm also a gym owner in Central New York. And then I also have my lovely co-hosts, Derek Bark. He's a chiropractic student and clinical athlete forum ambassador and intern. You'll also hear him on the student series of the Clinical Athlete podcast. And then our main person that's going to be hosting today is Natasha Barnes. So thank you so much for being here. She's a chiropractor, a rehab clinician. She owns her own online rehab business. She's a professional rock climber and a clinical athlete provider. So badass all around. And before we get started, I'm just going to do a quick poll just to see where everybody's coming from and who everyone is. So if you guys want to answer that real quick. Can everyone see it? Yes, perfect. Here we go. They're coming in. Lots of PT students, some clinicians,
cool.
Some chiropractic students, some others, which is interesting.
Others.
If you guys typed other or clicked other as to who are you, I'd love to know. If you want to just like write a little thing in the chat.
I also want to know if you're a climber. Let me know.
Oh, yes.
Then I know who I'm talking to.
Sweet. All right. So we have mostly PT, chiropractic students, and clinicians. Awesome. We have some others in there. And then we have so a lot of you, this is, do wannabe climbers count? Yes. So we have a lot of people. This is your first CALU event, which is awesome. And then a lot of people are interested in just everything. Most people want the brain gains. Who doesn't? Cool. All right, so I'm going to end that. Perfect. You guys can see what I'm looking at there. Okay. So we have the agenda for tonight or today, depending on where you are in the world. We're just going to start with a presentation of the case. Natasha's going to take that over. We'll head into a couple breakout rooms, depending on how much time we have. And then we'll wrap up the case and conclude with a brief Q&A at the very end. And that's all I have. So Natasha, whenever you're ready, the floor is yours.
Awesome. I'm just going to share my screen because my intro is in my presentation. So here we go. Where's my, this happens every time I do a presentation. I want to move everybody's face there. Okay. Okay, cool. Welcome everybody. Thanks for joining. We're going to talk about annular ligament injuries in rock climbers. Super, super rare injury in the general population, but actually pretty common in the rock climbing athlete, which is probably 90% of who I treat. And if you guys can, please make sure that you are muted for now. Just so that there's no weird noises happening in the background. So I am Dr. Natasha Barnes. I help climbers overcome injury and get strong AF. My mission is to educate and empower climbers to build resiliency through strength training and smart climbing programs. I spend a lot of my time convincing rock climbers to strength train. My educational background is I'm a doctor of chiropractic. I actually graduated from Palmer West in 2012. For my athletic background, I've been climbing for over 23 years. I'm a former professional rock climber, 2005 bouldering national champion. I've climbed multiple double-digit boulder problems and 14A sport climbs, all of that. I'm also a competitive powerlifter. 2019, I was the USPA 2019 Submasters national champion. Got 6th overall. Those are my powerlifting numbers if anybody here is a powerlifter and cares about that. So I'm a kind of a hybrid athlete, climber and powerlifter. So the injury we're going to talk about today is actually what literally motivated me to do what I do today. It's an injury that I've personally suffered from a lot. And it's an injury that changed the course of my climbing career. This is a picture of me in 2005, 16 years ago now, I guess. At a competition, at the very competition that I got my first pulley injury or annular tear injury. This was right after winning national championships. So for me, I thought it was over. I thought my climbing career was over. So this is an injury that's very near and dear to me that we're going to talk about in kind of like a case study format, I guess. So here's the case, just to present you guys right at the beginning. This isn't actually like a real case. This is just like what I normally would see. Like I see this all the time every week. Why did I pick a male climber? Just because the stock photos, this is the first stock photo I found. I don't know, this guy looks like he could be 26. So we have a 26, happens like males and females. So, you know, it's not that like this happens more to men than women or anything like that, but 26-year-old male climber. This is like common presentation. Like 3 weeks ago, he was feeling some soreness at the base of his right middle finger. He thought it would go away. He kept climbing. And then 2 weeks ago, he had a climbing session and he noticed the finger early in the session, but he continued to climb anyway. And then at some point in the session, he felt a pop while he was crimping on a hard climb. We'll talk about what crimping is if you don't know. And he tried to do some easier climbing after that, but it was just too painful. So he took a week off of climbing and the pain is still there. He's worried about making it worse if he continues to climb. He Googled a bunch of stuff. He's listened to some podcasts. He thinks it's probably an A2 pulley injury, which is an annular tear. But he's not sure and he's unclear about what the next steps are, like what he should do, despite getting a lot of advice from friends and from the internet. So it's like a pretty common case. This could literally be like any of the cases that I saw this week. So that's a case. So I want you to just kind of like keep this in mind as we go through the information here. So like, I want you guys to kind of think about like what follow-up questions we should ask. I think it's a little bit unfair to ask you that yet because I want to teach you a little bit more about these injuries. A lot of people here probably haven't seen these before or heard of these before. So I want to talk a little bit more about these injuries and go through like what they are, how they present, all of that, so that you guys have some background information and then we can like break out and like decide what else we would want to do with this patient, what questions we would want to ask and things like that. So let's talk about these injuries. So annular tear, annular ligament injuries are also called pulley injuries. That's what climbers call them. That's what they're called in my community. So we can kind of use those terms interchangeably, annular ligament, pulley injury. I'm not really sure where the pulley terminology came from, but that's just what people call them. And so this is kind of let's do a little anatomy review here. So a lot of people don't either don't remember finger anatomy or don't look at it this detailed because it's not relevant for most sports, but for climbing, it's really important. So here's a finger, and it's kind of like a finger. If I was like holding my finger, I don't know if you guys can see me like that. So down here, this knuckle here, this is kind of the base knuckle in your finger. So if you guys can see, it's like here on me, it's this knuckle. This knuckle here, just so we can get our bearings, is the pip joint, proximal interphalangeal joint right here. It's the middle knuckle. And then here's the dip joint, which is the distal interphalangeal joint. And then obviously you can tell by this fingernail, this is the palmar side of the hand. This is the dorsal side of the finger. And you can see here, so these are all labeled A1, 2, 3, 4, 5. There's 5 of them. So in kind of like your palm, you've got your A1, stands for annular pulley. A1, annular ligament 2, annular ligament 3 here, right under the pip joint. Annular ligament 4, kind of between the pip and the dip joint. And then you've also got a 5th one in the tip of the finger here. And then you can also see that there are these cruciform pulleys, which are these like X's here in the anatomy diagram. Hopefully you guys can see my cursor here. So those are some of the relevant architecture. And then we also have the joint capsules, which you can kind of see here around the pip and the dip joint. And then also relevant is the collateral ligament, which is basically like a ligament that runs on the side of the capsule right there. And then you also have your flexor digitorum superficialis tendon and your flexor digitorum profundus tendon. And it can be relevant to know that if you guys remember the flexor digitorum superficialis kind of attaches somewhere right around here, and the flexor profundus attaches actually in the tip of the finger here. So that's kind of the relevant anatomy. For my patients, and maybe for some of you guys, it makes more sense to see it on an actual hand like this. So that's why I put this photo so you guys can see. So here's the pip joint, here's the dip joint. And here's kind of like someone like drew on their hand, like where these pulleys would be and where we're looking at people's fingers here. So A1 is kind of down in the palm. A2 is like in the base, kind of in that crease of your palm. A3 is like right here in the joint, basically. A4 is above that, and A5 is right there. So you guys, just so you guys can see that. And then this is just like a diagram of what would be like considered a partial tear of the pulley right here, and what we would consider a full rupture. So the pulleys are just there to kind of hold the tendon to the bone. And they make the tendons able to do their job, makes your fingers stronger. It can be problematic. So having like a rupture of one of the pulleys usually isn't that big of a deal, but it can be problematic if you have a rupture of multiple of them, which is usually a traumatic situation. But when that happens, especially if it's involving like the A3, in the A2, you can get like significant weakness in that finger. And sometimes it is like a surgical consult, because you can, for a normal person, it might be fine. For a climber, you can lose significant strength in your finger, because this completely changes the mechanics of how your finger tendons work, your flexor tendons work, because you don't have those pulleys there anymore. And usually what they do for the surgery is they will take your palmaris longus. If you guys are, a lot of you guys are PT students, so you'll know like palmaris longus, not everybody has it. You can kind of do this and flex your wrist to see if you've got that middle tendon in your wrist. I've got it. You can see it. I don't know if you guys can see that, but you'll have a tendon that pops up right in the middle. You don't really need that, so they'll take that out and they'll use that to repair the pulley. Next slide. So let's talk about crimping, because some people here I think are climbers, but not everybody is, and so you might not understand this specialized grip that climbers use that it is important when we're talking about rehabbing these injuries, but also can be important when we're talking about the mechanics of like why these injuries happen sometimes. So crimping is just a specialized grip that climbers use to hold onto really small holds. And there's a couple of photos here you can see at the top of like what that looks like. So this photo here is an open grip. I kind of don't like the photo. You can tell they kind of, if you're a climber, you can tell they took this photo from standing on the ground because it's like nobody would grab a hold like that. But basically what we're looking at for crimping, generally speaking, is we want to see the pip joint at about 90 degrees or more. And we consider that crimping. Otherwise, if it's not, then we consider that like a more open hand grip, or drag grip is what some people will call it. So this is a crimp here. This is called a half crimp. These joints are basically at 90 degrees. And then this is called a full crimp. And the full crimp is basically like the hook grip of rock climbing is how I like to explain it. So it's kind of like hook grip, where like hook grip, you are hooking your thumb under the bar if you guys lift weights, and then reinforcing it with your fingers to get a better grip on the bar. Crimping is like that. It's just the opposite. So we're actually hooking our thumb over the top of our fingers to reinforce the index finger. And it's a really, really strong grip. For most people, it actually brings their knuckles at more than 90-degree flexion. So just so you guys have like some awareness of that. So we've done some studies on this, and this is like a photo from the study. If you guys want like links to some of these studies too, I can send like a link, like a resources or a links list or whatever. Bibliography, whatever you want to call it. I can send that over, but this is from that study. And you can see how they're measuring this here. So we know from some of these studies that the force on the A4 pulley, which remember is between the pip and the dip, that's right up here, increases about 4 times in a crimp position, which is this top photo here, versus a slope or a more open hand position, which is the bottom position here. You can see the difference in the knuckle angle. And then the force on the A2 pulley, which is at the base of your finger here, which is like a little bit more commonly injured in climbers, is the force increases there about 36 times while crimping. Some people will actually use this information in almost like a nocivic way and tell people that because that force is increasing, that they should be avoiding crimping at all. But crimping is actually like a very important grip in climbing. It's a stronger grip. It's going to allow you to climb harder. It's an important grip for the sport. So yeah, I don't really recommend telling people not to avoid this position, because we need it in climbing, and telling people to avoid this position just because there's an increased force here, you know, kind of ignores the fact that our bodies can adapt to stress. And, you know, it's the same thing for like, you know, we know ACL peak forces are in 15 to 30 degrees of knee flexion, but we're not telling people not to like squat or not to sit on a toilet because it's dangerous for their ACL. Same thing with patellar tendon forces in running. You know, it's increased in running, but we're not telling people not to run because of that. So same thing in climbing. But a lot of people do come into the consultation knowing that crimping does put more force on the A2 pulley, and they're really scared of it. Or they think they did something wrong. They're like, well, yeah, I was crimping, so obviously I got hurt. There's nothing wrong with that grip. So I always try to make sure I educate people on that. Come on, Tosh. I just put this video in so you guys can see some crimping in action. In case you're not a climber, this is a video of me climbing something really crimpy. I just have some close-ups of like some crimps. You can see how small those holes are. I think that's it. Yes, you can see how small those holds are, and that happens a lot in climbing. So let's talk about prevalence. So we have some evidence here. This is the most recent between 2009 and 2012, this is during a 4-year period, they looked at 136 patients with a total of 911 climbing injuries. And they found that about 833 of those were in the upper extremity for climbers, 58 in the lower extremity, because lower extremity injuries still happen in climbers. We fall, we use our legs and stuff like that. So finger injuries accounted for about 52% of all of the injuries that they were seeing here, and pulley injuries were the most frequent of the finger injuries. So they're really, really common in climbers. Like I said, not so common in the general population. Um, in this paper here, 20 injured young climbers. There were 20 of them under the age of 15, and all of them had an epiphyseal fracture, which is going to come into play later. We'll talk about that. And then how do we diagnose these? So the gold standard is considered dynamic ultrasound. So we can look at how much the tendon is bowstringing. So we're looking to see how much space there is between the bone and the tendon during the ultrasound. So you can have a climber actually go through different grip positions and put different force on their fingers and look at it under ultrasound, and we can measure this. And so we found that bowstringing, we can see it from 0.5 millimeters for like a partial pulley tear up to 8 millimeters if there's like combined like multiple ruptures in the finger. So you can look at it that way. MRI can be acceptable as well, and generally they're considering like if you have greater than 1 millimeter of space between the tendon and the bone on MRI, then we're considering that a rupture. But this can be a little bit problematic. I had a case of a climber who, she was 17, so we referred her out for imaging because anytime a climber with finger pain presents and they're under the age of 18, it's generally recommended to get imaging because the research shows that like 100% of those generally are epiphyseal fractures, and we want to rule that out. So she went to get imaging. She only had pain in one finger. The MRI report came back, and this is the most baffling MRI report I've ever seen in my life. The MRI report said that she had ruptured every single pulley in every single finger of her hand. And that just wasn't the case because she, that just wasn't the case. And so I talked to somebody who does a lot of this research, my friend Yasser, who's the author of this paper here. And he actually said that if you're hypermobile, and she happened to be hypermobile, you could actually see more than a 1 millimeter distance between the tendon and the bone, and it doesn't necessarily mean that it's ruptured. So yeah, interesting. So a lot of people also think that you can diagnose these injuries by going into the clinic and stress testing the finger and looking for bowstringing, but it's not a reliable way to look for these things. And the only time you're really going to see bowstringing is going to be if the A3 pulley is ruptured or if multiple of the pulleys are ruptured. So the dynamic ultrasound is recommended. I don't actually do this in my clinic because I don't have a dynamic ultrasound, and I don't think, unless I'm thinking that somebody is surgical, in my opinion, the imaging's not that important because they're probably going to respond to rehab anyway, and I don't care to know, what grade it's ruptured. It doesn't really matter unless we think maybe they're surgical. And then there's also classification for this. My friend Carrie Cooper did this paper where they were trying to figure out a way to classify the injuries, and they're classifying them based on pain, based on active range of motion, based on resisted tests and what kind of pain you're having, weakness and pain you're having on those, and then palpation. So just so you guys know, this paper is available and out there. I don't think it's personally helpful for me to categorize them. I think it's probably important as a first paper for establishing more research on this stuff and establishing like rehab protocols that we can study. Like, of course, we're going to have to like find a way to classify these things. But for me personally in the clinic, like it's not really that important. Like really, I'm just trying to rule out is someone surgical or not. And if they're not, then it doesn't matter. We're just going to figure out a way to rehab. So, but if you guys want to go look for this, this is available and out there for you. So let's talk about differential diagnosis, red flags, things like that, things that you might want to know going into this. So we want to rule out epiphyseal fracture. These are generally going to happen for kids who are climbing between the ages of 10 and 14 for girls and 12 and 16 for boys. It's generally recommended that if someone is under the age of 18, we need to rule this out because a lot of the studies have shown, I think there's one that shows that like 90% and one that shows like 100% of the time when kids in this age range have finger pain, it's more than likely going to be one of these things. So when kids are young, their fingers aren't fused yet. Their growth plates aren't fused yet in their fingers. And they can fracture, they can get a Salter-Harris fracture in their fingers. And you can kind of see it on this photo up here. If we look at it from the sides, you can see this finger just looks swollen. But then when we look at it under imaging here, you can see there's a fracture. And that can be problematic because if they get a growth plate fracture, that can significantly affect the growth of their finger, and it can cause a lot of problems for them. So we're looking for the growth plates to be fused. So, the quickest way to do that would be to get an x-ray, and we can just quickly look. If the growth plates are fused, then we're not worried about it. If they're not, then yeah, we're kind of worried about it. And you can also get an MRI to look at this as well. But we definitely want to rule this out because this can be a problem. And with the climbing is just growing really, really fast right now. There's tons of kids that are climbing. There's tons of kids teams. There's a lot of young, climbing's about to be in the Olympics, so there's a lot of young kids who are getting really serious about training for climbing. So this is just something to be like super aware of, because I've seen a ton of kids with finger injuries, and the kids get them because they're training a ton at the climbing gym. So typically for these competitions. And then, we can, like I said, sometimes you can see this bowstringing. Generally, it's going to be only if there's been like a traumatic injury with multiple ruptures, and you can kind of see, normally it wouldn't look like this, but you can see the bowstringing there. If I can actually see that in someone like in the clinic, it's pretty likely that they've got multiple ruptures, and probably going to refer them out for a surgical consult, just because we're worried that if it's the A3 plus A2 and or the A4, the climber can like lose significant strength in that finger because it changes the mechanics of the tendon here, and that can be problematic for them in the future. So we just want to make sure that we look out for that too. And then there's also some other things that people will come in with that they think is a pulley injury, and it's not, or they'll come in thinking that it's like a flexor tendon strain and it's a pulley injury. So these are just things to kind of like be aware of. A flexor tendon strain can happen. They're also very common in climbing. This is probably one of the more common things I see, other than annular ligament tears. This is the mechanism for this one is different though. It's a tendon injury. So it usually happens when the tendon's being eccentrically loaded, or when someone's in a more open-handed position, which the tendon is a little bit more stretched out, and then they're producing force in that position. And generally it's not going to be localized pain. It's going to be pain through the whole tendon, or pain just in the forearm or something like that. And then we also want to look for collateral ligament injuries, which can feel like a pulley injury, but generally those are going to be around the PIP, the PIP joint. Generally going to be pain or swelling localized more on the side. The mechanism is usually a little bit different. So sometimes there's an event, like when people are climbing finger cracks, they have to like stick their fingers in a little crack and like twist their hand to lock their fingers in. And sometimes that can result in a strain or a tear of the collateral ligament. And with those, I'm generally looking, like you'll see swelling more on one side of the finger when that happens. But they can present really similarly to pulley injuries. And then a capsular injury, which is just like a joint capsule irritation or strain or whatever. For those people, it's usually like the actual knuckle is swollen and it's just the knuckle. And it's a little bit different than the pulley injury. And then tenosynovitis. I don't see this one as much, but this one it's worth knowing about. That's just inflammation of the sheath that goes around the flexor tendons, and you can get irritation from that. Usually there's going to be some swelling or you're going to feel some pain through the whole finger and into the palm. These usually respond really well to just like rest and anti-inflammatory medications and also adjusting training. So just something to know. And then something called lumbrical shift or lumbrical strain. So you've got muscles in your hands in between the bones in your hands called the lumbricals. They assist in your hand doing that position, or like if you're grabbing like a pull-up bar, a deadlift bar, anything, a climbing hold, you're using your lumbricals. So some people can get a lumbrical strain. Sometimes it happens if you're holding onto a hold and your pinky pops off quickly. What it does is when your pinky pops off, this finger is being pulled down. Well, this finger is being pulled on this way from being loaded, and you can get like a strain of that lumbrical. Or like sometimes when people actually injure their A1 or A2 pulley, sometimes you'll get a lumbrical strain with that. Generally, that's going to be pain in the palm of the hand in between the fingers. And sometimes you will see some discoloration there. If it's a big tear, it bleeds, and you can see some discoloration there. So these are just like this is not like everything, but this is just some stuff that's worth knowing about that you might want to rule out. Because I've definitely had people come in and they've got a collateral ligament injury and they think it's like a pulley injury. So let's go back to the 26-year-old male climber. Just to remind you, the injury was 3 weeks ago, or he was feeling soreness 3 weeks ago in the base of his right middle finger. He 2 weeks ago had an event where he felt a pop. He decided to try some easier climbing, but it was still too painful, so he took a week off. But the pain is still there, and he's worried about making it worse. He Googled and listened to some podcasts. He thinks it's an A2 pulley from what he's read and heard from friends, but he's unclear on what the next steps are. He's gotten some advice from friends and the internet. So that's kind of our case, just to remind you. And so I guess my question for you for the breakout room, now that you know what you know, would be what follow-up questions should we ask this patient? What do we need to know to rule out red flags or to differentially diagnose this injury? And what do we need to know for developing a rehab strategy?
Awesome. Natasha, if you could stop sharing your screen real quick, then I can put us into breakout rooms.
Cool.
Let's see. You actually might have it on your end, Natasha. If you look at the bottom, there should be.
Oh, breakout rooms. Should I click it?
Click it and then allow it to automatically assign.
Cool.
And if we want to let's do 5 breakout rooms. Can you choose a number?
Yep.
Perfect. And then whenever you're ready, you can click go ahead to it.
There we go. And then should I click open all rooms or
yes.
just?
and then everyone has a.
I've never done the breakout room, so I don't know how it works. So, guess we're all in a room together? I don't know how it goes. Hi, everybody in this room. Can you guys hear me? Max? Okay, I'm in a room. No, you guys are leaving. Okay, I've never done these before, so I think I'm in a room with Shannon and Sandeep. So if you guys want to let me know what questions you might ask, or if not, if you just want to chill, you can also feel free to unmute yourself. Shannon, I think maybe you're unmuted, but I can't hear you. I still can't hear you. I'm just gonna check out the questions. Let's see. Ooh. Now I can hear you. All right. Good chat, everyone.
Awesome. Did we get, here we go. Here's everybody else. Sweet.
People are popping back in.
Yes. It looks like some people still might be chatting a little bit. That's good.
Lots to chat about, to be honest.
I know. Do you guys feel like you had enough time in your breakout room? Yes, no? Okay. We'll adjust it if we need to for the next one. Ooh, yes. Jared, I love the reaction. I actually didn't know that that was a thing until like the last Zoom meeting that I was on.
Yeah.
But they're fun.
Have you seen that guy on TikTok that like trolls people's like Zoom meetings? Like
what?
like
No.
it's so funny. Oh my god. He just like shows up in like classrooms and like acts like he's a teacher, and he's like, and then the teacher's like, who are you? Like, what are you doing here? He's like, I'm just making sure all the students are behaving.
Oh my god.
It's really funny. He's got a bunch of really funny skits where he like actually trolls like real Zoom meetings and stuff.
That's hilarious. Sweet. I think we have just about everybody back. So whenever you're good.
Okay. I don't know if we want to actually talk about. I'm just gonna show you my slides of like the things that I'm usually looking for when people come in, and you know, we can talk about it, or you guys can ask me questions about it. Let me move the little bubble of people here. I always have a hard time moving the, okay, there we go. Okay, so these are kind of like the main things I'm looking for. So age, we already know he, in this case, you know, he's over the age of 18, so not really worried about like epiphyseal fractures, but we definitely want to look at that for sure, because like I said, if they're under 18, we want to make sure that we're ruling that out, because the research shows us that most of the time it's probably going to be that. And then obviously looking for real obvious like bowstringing and discoloration, because if we're suspecting, and then, you know, asking about trauma, so like an event, a pop, something like that, a foot slip where they heard like a pop or multiple pops, kind of looking at that, because that potential, or imaging reports that they may have, because I might actually have like refer them to a surgeon potentially if that's the case, or at least talk to them about that. And then, and honestly, I've only seen one of these before. When this stuff happens, when people have like a multiple ruptures, it's like a pretty big deal, and they're usually gonna go straight to a surgeon anyway. I've seen people after the surgeries, or I've worked with them with the surgeon on these injuries, but they're usually not coming to me first when they have that, just so you guys know. But still want to look at that. And then what I want to know, like, what has this person been told about their injury? What have they read about the injury? Because there's a lot of like information out there, both good and bad, about these injuries for climbers, and, you know, just like anything. And I also want to know what they've been told, because that's potentially going to help me educate them, or you know, just get an idea of like what they might think is going on, or what they think needs to happen, or what they're expecting to happen next. And then I also like to kind of know if there's any kind of climbing that they can do that doesn't aggravate their injury. And I usually try to talk to people about this, because it's okay to have some discomfort with a rehab. Like, you guys probably know this, like some discomfort can be okay. It's part of the rehab process. So I try to educate my clients on this. And what I'm usually looking for is, like, it's okay to have tolerable discomfort. You should kind of return to baseline within like 48 hours after the session. Like, you should feel like you could do that session again, maybe in 48 hours. And if not, if you feel like you're worse, or you feel like you're having to modify your next session, then that's potentially means that what you did is aggravating the injury. Your body can't tolerate it. So we need to adjust. So I'm trying to find out if they know if there's any amount of climbing that they can do, because I like to try to keep them climbing as much as possible so that they don't decondition from the sport. And a lot of times there is still some climbing that they can do. And then particular for this injury, I also usually have to educate the client on the difference between the injury hurting because they're actually putting like mechanical stress on the pulley versus the injury hurting because they're grabbing like a climbing hold that's sort of like digging into where it might be sore. And that happens. And sometimes people feel that. And this happened to me when I first had my original injury. I felt that and was like, okay, I guess I still can't climb. That kind of discomfort is okay. Like it's okay if you're grabbing a pull-up bar or a jug and you can kind of feel it pushing on the sore pulley. Like that doesn't mean you should stop what you're doing. So trying to help people understand that and also differentiate like between those two kinds of pains. And then I also like to know if there's any specific positions or grips that seem to aggravate it, because sometimes people are like convinced it's a pulley injury and they're like, oh yeah, but if I like pocket pull with 2 fingers, it really hurts. And then I feel it down into my forearm. Okay, that's a different injury. And like, we're going to approach the rehab probably differently. So this is also a good question to ask. And I also want to know if there's any grips or positions that they're nervous about, because sometimes when people get a finger injury, they're really, really scared to crimp again or to close crimp. Or like I said earlier, they've been told not to do that because it's dangerous. And I want to make sure that I'm grading their exposure back to crimping, because it's a really important grip in climbing. You're going to encounter it. And so sometimes we have to do some graded exposure back to that particular grip. So I want to know kind of where their head's at about that. And then, do they have any experience hangboarding? Because we're probably going to do some hangboarding, which I'll tell you guys about in a second if you don't know what that is, for rehab. And a lot of climbers have experience with this. Some climbers have no experience with this. And I want to know if they have, because then they're going to understand the rehab a little easier. If they haven't, then I'm going to have to do a little bit more explaining and probably make sure that they're comfortable doing it. And I also want to know how comfortable they feel about loading the injury. So these injuries respond really well to loading and like helping people grade their exposure back to climbing and using the finger. We just have to find a good entry point for them. So I'm always trying to get an idea of like where their head is at about doing that. And some people are like, yes, absolutely, I want to get back to climbing. I'm ready. Let's go. Or I figured we would be doing something like that. Like, let's go. And other people are like, honestly, I'm really scared. Like, I'm scared I'm going to make it worse. Like, I don't even want to open my car door because like I'm just nervous to load the finger. And in that case, like I'm going to have to help ease them into the rehab a little bit more. So always looking for that too. And then we can talk about how we rehab these things. But does anybody like have any questions or want to talk or want to like mention any of the questions that they thought to ask? I'm trying to look for, where's my
There's a couple questions in the chat.
Yeah, I'm like, where's the chat? Oh, here we go. It's covered. Let me see.
So Marcus said, what was the position of the hand when it happened?
Yeah, we can definitely look at that. We can ask people that. Sometimes they know and sometimes they don't know, because if they're like in the moment and they're not really sure like how they were grabbing something, so they don't always know. Sometimes they have a video of it. I have a video of my pulley actually audibly popping, and you can hear it in the video. And I thought about putting it in here, but I didn't. And then Natasha says, what's an average climbing frequency? How many days per week do they climb, and how do you gauge intensity? It's going to differ from climber to climber. So it's not like the kind of sport where it's like powerlifting or weightlifting where people like go to the gym and they know they're supposed to get on a program and then they know they're supposed to be on a certain type of like frequency. Climbing is kind of like very recreational in that people have all kinds of frequencies. And so I always want to ask the client, like, what's normal for them and what are they doing now? has there been any changes in their routine recently? And sometimes you'll ask and people will be like, oh yeah, I started this like new training program like a month ago that I found online, so my volume has gone up significantly, or something like that. But I always want to get an idea of like what their climbing frequency is. And I've worked with people who are like only climb once a week, and I've worked with people who climb like 6 days a week, which is kind of a lot. So it really depends. I would say on average, like most people are probably climbing at least 3 times a week. 3 to 4 is like kind of what I see on average. And then intensities can be a little bit hard to gauge because it's also not like weightlifting where it's like, okay, you're deadlifting 245 pounds today. Climbing does have a grading system, but it's very subjective, and it's hard to measure the actual intensity of the climbing session through the grade, because the grades can feel different for different people depending on like your height, your body proportions, like what kind of climbing you're good at, and how good your technique is and all of that. So it can be a little bit hard to gauge that for people. Let's see. It's a huge range. I used to climb 6 times a week, but now it's 1 to 2, just like any other sport. Intensity can also vary widely because there are different disciplines. Yeah, RPE is an option. Yeah, I'll do that for people like session RPE or something like that. Personal grades, like we can do something like that. How often can you calculate intensity based on, or often you can calculate intensity based on a person's highest level of climbing and scaling back? Yeah, so we can look at like how hard it is for them. Like, oh, I climb up to V4, and then we can be like, okay, so that's kind of like your range. Or I climb up to V8, okay, that's kind of like your range, and we can look at it that way. Would you prescribe low intensity hangboarding to climbers early in their climbing career as a preventative mechanism for pulley injuries, or would you say this is a higher risk? So there's like a really big myth out there that like hangboarding is high risk for beginner climbers, but I think it's a little bit of a misconception because we can start people with where they are at, and we can go from there. So that means you can start with hangboarding if your fingers can handle actually hanging body weight on a hangboard, or we can start with something that's easier than that. And we're going to talk about this, but I'll just show you this now. There's things like that, like this. So this is like a grip. This is actually like I like the tension block because it's wood. But there are different holds on this. So we can actually have someone use something like this, and we can clip weight to this, or to like a loading pin, or to some dumbbells, and we can actually have them load less than body weight. So I've worked with climbers where their finger injury was so uncomfortable and like acute that like we literally did like 5 pounds on this. And I've worked with other people who were able to add body weight plus 35 or more pounds, and that was like their starting point for rehab. So it's going to depend on the person you're working with, but I definitely do recommend hangboarding. I think it's a really controlled and measurable way to strengthen your fingers that can help probably reduce your risk of getting a climbing injury. Obviously, we don't have any evidence on that. Climbing's like a pretty new sport. It's not been studied, but from what we know about other sports, if you're strength training, it's going to help reduce your risk of injury. So I apply that to hangboarding for sure. How do I move this box? Technical difficulties. I'm just going to click around until something happens. No.
If you move the where the people are, you might be able to X out of it.
I know, I'm trying to like move the people. Okay, there we go.
You got it. You got it.
I do this all the time and I have the same problems. Okay, there we go. Okay, so let's go forward. How do we rehab these things? Or like what are next steps for people, or what would be the next step for this person? So usually the first thing I'm trying to do is educate them and reassure them. Some people don't know anything about annular ligament injuries, even though they climb, or whatever injury it is that they have that's climbing related. So I try to educate them on the injury, and I reassure them that, this is something that responds well to rehab most of the time. I do see a lot of climbers with these injuries. And so I assure them that, like, you know, we've done this before. I've seen this for other climbers as well. So I like to make sure that they have the information that they need to feel comfortable about what's going on, and reassuring them that everything's going to be okay and we're going to find a way to get them back to climbing. And then we talk about rehab and load management. So first thing we're going to do is find a starting point for rehab. So let's find out what we can do to load their finger. And where's their starting point? Is it going to be 5 pounds on this thing, or are they going to be actually hangboarding? And I actually have a hangboard and these other devices in my clinic that we can use to look at that. I also have a crane scale, so if we want, we can measure it that way. I just use the load as a way to measure most of the time. And then we're also talking about, like I mentioned earlier, like how much do they climb? What's normal for them? What are they doing now? What are they able to do now? If they're not sure, then we can have them go into the gym and find out what they can do. And for me, I like to keep their climbing sessions, at least initially, like pretty pain-free, because I want to get a good read on how the hangboarding is, how they're tolerating the hangboarding, basically. And if they're doing climbing and they're not navigating that well, and then they're also doing like the hangboarding and then their fingers like still hurting, or it's like not responding well, then it can be really hard to tell, like, okay, is it the climbing that you're still doing, or is it the hangboard? Like, we're not sure. So I want them to keep climbing, but like initially, until we get an idea of like how they're going to respond to the rehab side of things, we're keeping the climbing like pretty pain-free at the beginning. So we're discussing that with the patient. And then I'm looking at their mindset and their buy-in. I kind of hate the word buy-in because it sounds like kind of sleazy salesman guy to me, but you guys know what I mean. I want to find out like how comfortable they feel about loading their finger, obviously, because if they're really scared of it, we're going to have to probably take it a little more slowly, or we're going to have to talk about like why this is okay to do. And then I want to find out like how confident they feel in the plan. You know, and it's a really important thing to ask, and you'll be surprised when you talk to people, because you think that they're on board, and then you're like, so how do you feel about this plan? Like, what do you think? They're like, I don't know, I don't understand how this is going to work. Like, I don't understand how this helps. Like, I've had people say that, and then so we have to have a conversation about that, because if they don't understand how the rehab's going to help them, then it's probably not going to help them. So that's really, really important. And then also making sure that they understand the plan too, which we're going to talk about the plan in a second. But I really want to make sure that they understand how the plan works, like how the rehab actually works. And so for most patients, this is like actually a slide from the thing that I'm going to be giving to patients soon. But basically what we're going to do is we're going to find where their entry point is. So, you know, what's the most challenging thing we can do with your finger that gives you a tolerable amount of discomfort, or maybe even no discomfort. And then we need to progressively overload it. So this is something that like we take for granted. If you're an athlete, or if you're a physical therapist or a rehab professional, like you understand that your training needs and your rehab needs to get harder over time. Our clients don't understand that sometimes. Like they think that they're going to do body weight hangs forever, and like that's just what their rehab is going to look like. They don't understand that it needs to get harder. We need to progressively overload their rehab in order for them to get better. And you'd be surprised how many people don't actually know this of our clients, because they don't study this stuff like we do. So I always try to make sure I explain this to clients. And then we want to find a way to like desensitize their injury. And sometimes just finding that entry point and starting their loading will do that. For some clients, like we really also have to figure out grip positions that maybe really bother them or that they're scared of. So for most climbers, I actually will have them rehab in that half cramp position that we mentioned. So that's this 90-degree position for the hip joint. But some people are really scared to do that. They're really scared to wrap their finger. So we're gonna design some part of their rehab that exposes them back to that. And they could be doing like, you know, body weight hangs on a hangboard, but then maybe I'm giving them this and there's like a small edge on here. There's like a 7 mil edge on here. Maybe I'm having them do some like rolling into a close crimp on this to like get them okay with doing this again. Because for some people they're scared of it. For some people it's actually a really sensitive motion. So always looking for that too. And I always try to educate my clients on the fact that rehab is really just training from a different starting point. Like we're just training your fingers. That's all we're doing. We're just finding a new starting point for you because there's some pain or there's some discomfort. But it's training and it works exactly like training. So pulleys are ligaments that need to be loaded in order to stimulate healing. And it's safe to load them. We just got to find something that's tolerable for the client. So I use a hangboard. This is like me on my hangboard in my backyard, hanging on my hangboard. So I like to use the hangboard. We don't have to use a hangboard. Like I said, we can use some kind of grip device like I just showed you. You know, if somebody doesn't even have that, we can use like webbing or straps. Like you could even use something like this and we could like hang it on your finger and load your finger that way, you know, if that's all you have at home. So we can find ways to load the finger. And so like I mentioned here, we can use the tension block, which I just showed you. It's this guy. And this is kind of how it works. If you're having a hard time like picturing that, you can just hook some weight to it and load the fingers that way. And the nice thing about this one is that like it has a bunch of different edges on it. So like if I wanted to isolate the one finger for some reason, I could do that. Or, you know, for some people, like it's this half crimp position that's bothering them. For other people, it's a more open hand position and like the pocket could work better. On this, I can also do, we can pinch it. So we can grab here and we can actually train like pinch if we want to. So there's a lot of things we can do with this. And you can start, like I literally have the capabilities to start somebody as low as like a 1/4 pound because I have 1/4 pound fractionals, you know, so we can really grade someone's exposure with this and they don't have to start with body weight. Otherwise a hangboard is pretty ideal. I really like these tension boards because the wood is really easy, really nice on your skin. And also the edges are measured on these hangboards. So I know exactly how big the edge is that they're using. And I don't know if you can see in this photo here, but the measurements are all here, which is really, really nice. I can tell someone, okay, grab the 20 mil edge and they know which one to grab. Some hangboards don't have that. So it's like hard to, you don't really know like how big the edge is unless you measure it. For the hangboarding rehab, and also there's ways to do it on the hangboard with taking weight off. So you can use like a pull-up, like the bands that people use for pull-ups to offload it. You can use a pulley system. So some people will set up, like rig up like an actual pulley here, and they'll tie in to their harness, their climbing harness, and then they'll offset it with like some weight. So you can offload that way. That way's a little bit more complicated, but it does work. And I've had clients do that. And then, yeah, so that's the way that I like to do it. I find that for most people, just because of what we're trying to target with this rehab is the pulley. So we don't want to grab edges that are too large. If you're on a big edge, it's not going to stress your pulley adequately. So my recommendation is using something between a 20 and 25 millimeter edge, which for most people is going to be like that first pad of their finger. And that sounds really crazy to like normal people, like what, you're asking your rehab clients to hang on their fingertips? Most climbers can do this. So it's actually not that crazy for a climber. But some people can't, and so we can use the tension block, or it is also okay to go slightly bigger if they need to, and we can work them to the smaller edge. I've worked with some like elite level climbers who are like V13 climbers, And literally the starting point for one of those climbers was on the 10 millimeter edge with 35 extra pounds hanging off of him was the only way we could like stress his fingers like adequately. And so that's where we started. Sounds crazy because that would be like really, really great training for most people, but that was like his rehab starting point. So it really, really depends on the athlete. I don't know why my family is like blowing me up with text messages. Can you guys see that? Okay, good. So the rehab protocols that I like to use, and you could do this so many different ways, and there's other people who do this a little bit differently, but this is the way that I like to do it. So Eva Lopez is a climber from Spain. She's a scientist and a climber from Spain. She's really strong. She's climbed up to 14C. If you guys are climbers and you know what that means. Really, really strong. She actually has her PhD literally on finger strength training. So she's a doctor in finger strength training, and she's got some good research on protocols for climbers. And I really, really like her research and her protocols. And I like them for two reasons. I'll tell you why. Number one, they're auto-regulated, which you don't really see in the climbing world much. So what that means is if you guys are into like lifting weights and you understand RPE or you understand reps in reserve, RIR, it's very similar to that. So you're given like a time to hang, and instead of like reps in reserve, we're using seconds in reserve. So how much longer could you hang? And so it's a way of auto-regulating the hangboard training. And I use this for just regular hangboard training as well, not just rehab. But it's a way to help climbers auto-regulate their hangboard training so that it's appropriate for them. So we're leaving seconds in the tank. And one of the things that a lot of climbers do is go to failure in their hangboard training and also in their climbing training. Like that's what a lot of people do because they don't know any better. And, you know, going to failure all the time in this kind of training can make you accumulate more fatigue than you can recover from, and then you stop recovering from the program. This program stops working, and for rehab purposes we definitely want to keep you away from failure, and so this does a really good job of that. So the protocols, like these are just some examples. There's a bunch of different ones that we could use, but this one is like a 15-second hang protocol with a 5-second margin, or she calls it an effort level in her research. So what that means is you're going to do an intensity where you're working up to a 15-second hang and you're leaving 5 seconds in reserve until failure. So essentially we're looking for like a 20-second max, but we're only going to hang it for 15 seconds. Or if we want to make the intensity a little higher, this 7-second hang with a 3-second margin. So essentially a 10-second max held only for 7 seconds. There's lots of different ways we can use these parameters, but I like to use this. And the climber can, work up to an intensity that they're comfortable with, that's appropriate for them, while being mindful of their discomfort. So some climbers are able to actually work up to these intensities, with an injury, and that's fine. Some are not. And so for some people, we're just listening to their discomfort and working up to what they can do. And then as part of the rehab, working them up to these intensities eventually. So that's why I like these protocols, because this is built into her programming and climbers respond really well to it. It also teaches them about training and it teaches them about auto-regulation, which most climbers don't actually understand much about training because it's just not something that most climbers do. And also, they definitely don't understand about auto-regulation. And I think that's a really valuable skill to have as an athlete. So that's why I like it. And it also progressively overloads for you, like her protocols. So they start pretty low volume, which I think is actually good for rehab. So we can get a good read on if you're going to respond to this protocol. And then it ramps up the volume over 4 weeks. She incorporates a deload. So if you wanted to take a deload, or if I want the client to have a deload, as part of the rehab or even as part of training, that's incorporated here. And then it transitions nicely. It goes from being like rehab and transitions really smoothly into like, okay, now you're actually just training. And it's not uncommon for my clients to come out of rehab with stronger fingers than they had before the injury. So, which is pretty nice. That's really all I have. So we can just do the Q&A now. You can find me at Natasha Barnes on Instagram if you guys are interested, or at my website, which is natashabarnesrehab.com. I'm going to stop sharing my screen.
Awesome. And then I think Derek is going to take over and he's going to help facilitate some of the Q&A stuff for you.
Yep, I'm going to do my best to help here. All right. So I know some people have asked some questions before we got to this point, so I'm going to kind of go back.
Yeah, let's see.
I did put a message in the chat. So again, if you'd like to unmute, just go ahead and type in question. We'll call on you to unmute and you can ask. If not, go ahead and just type it into the chat. We'll read it out loud and we'll go from there. So Ethan, it looks like you had a question in the chat. Do you want to unmute and ask that yourself? Or if not, I can just read it for you.
Yeah, sure thing. Oh, you can see it.
Oh, I can't see your question, but I can see some of the questions. Go for it.
Yeah, so I was just wondering, personally, like I have a background in strength sports and then I started climbing about a couple of years ago. So I've always kind of wondered about like, do you find that people coming from other sport backgrounds, especially now that a lot more people are getting into climbing, have a higher risk of injury because they have like strong bodies and maybe a higher strength potential, but like their tendons aren't conditioned enough? Or do you find that skill kind of is a barrier to that kind of risk?
It's hard to say. I mean, I think some people, when they're athletes already, they kind of understand easing into things and they kind of understand like how almost to not actually auto-regulate in the way that I was talking about, but like how to almost auto-regulate like their climbing. And so sometimes it's not a problem, but some of them, because they're athletes already and they are strong, they do tend to ramp up like really, really quickly into the sport. And, you know, we know that like tendons and ligaments take longer to adapt than muscle. So I think maybe sometimes it can be a problem, and I have seen that a little bit, but I don't think we have evidence on that, and I don't think I have enough. I don't know. I would say it's 50-50. Like I've seen both, honestly, on that. But yeah, it's a good question.
All right, Zach, it looked like you had a question previously. Would you like to unmute and ask that, or did she answer that already for you?
I'll unmute. I don't recall if you answered this, but how long do you typically see these rehabs taking?
Yeah, I try to get people to do at least 8 weeks of this rehab. Probably longer, like ideally like 8 or 12 weeks of this, just so that we know we're getting the adaptations that we're looking for. Some people will actually be like pain-free way before that though. But I'm gonna have them go through a few cycles of the protocol, and most people end up liking it anyway because they see how it makes their fingers feel good and how much stronger their fingers are actually getting from it too. So most people continue on with it anyway.
Okay, cool. Thank you.
All right, and then Quinn, I see you have a question you want to unmute and ask.
Sure, just real quick. First of all, Natasha, this was awesome.
Thank you.
Thank you for sharing all of this information. With the auto-regulation strategies, that was super interesting. Basically time to failure. There's some stuff in the conditioning and endurance world with that too. I think that's genius. Do you find that is intuitive, that scale to most climbers, or do you have to kind of anchor them a little bit over time to what actual failure does feel like so that they can kind of reverse engineer that perception?
Yeah, that's a really good question. It's not intuitive to some people. And I mean, I think it's really similar to like trying to teach athletes how to use RPE or RIR anyway. Some people will find it intuitive and they kind of have a sense of like how much they should do and other people don't. I don't think for rehab purposes, like we necessarily need to obviously take someone there to figure it out. I think they can usually get pretty close to what's appropriate for them, and that's fine. For training purposes, sometimes I will have people go to failure or go close to failure just so that they can have that experience and be able to use it a little bit more accurately. So one of the protocols I use is like a 5-second hang with a 1-second margin, and like the closer the person can get to failure, the easier it is to like know how close you are to failure. So that 5-second with a 1-second margin protocol like works pretty well for people for figuring that out without necessarily taking them to failure. But that's a really good question, because I know people do have a hard time with that with RPE and RIR training too. So.
Perfect, thank you.
All right, Chris, if you want to go ahead and unmute, you can ask your question.
Yes. So for rehabbing and putting them on the hangboard or the tension block, because it's, you know, a very easy to access, I'm assuming, like at their house or wherever they are, do you set restrictions on kind of frequency throughout the day? Or because it's really like dependent on their tolerance? Because I'm assuming like it's not a large systemic fatigue, so they have the motivation to do it a lot throughout the day, but do you kind of have set expectations of like, you know, certain frequency for this rehab?
Yeah. So I'm giving them like a specific frequency of when to do it. For most people, like every other day works well, or like 3 times a week at least to start, because I like to have that window, that 48-hour window where we can see how their finger is responding to the rehab as well, and also give them a little bit of time to recover from the last session going into the next session. So I don't really have problems with people like wanting to do it more than that, because I give them like a specific protocol to follow with like a specific number of sets and like a frequency and stuff like that. So it's usually okay, but sometimes that's a question that I get. So I definitely want to make sure that people understand like how the protocol works for sure. Yeah. And you can also, I mean, there's different strategies for rehabbing. It doesn't have to be like the protocols that I mentioned are great, and I like to use those primarily, but there are other strategies that you can use where you can have someone be doing these hangs more frequently for longer periods of time so that the intensity is a little bit lower. And in those cases, like I would maybe have someone be doing like maybe multiple sessions in a day or something like that, but it just kind of depends on the athlete and the situation, what it seems like their needs are going to be.
To add on to that, let's say like they're so intolerant to other climbing positions that's really all they can do, are you programming in other things just to not have them detrain in general?
Yeah, like if they can't climb at all, then we can have them do some forearm training. Like we can have them, usually people can tolerate like finger curls. So we can have them do some metabolic work that way. We can have them do BFR training and at least keep their forearms conditioned, or other exercises, strength exercises, pull-ups, weight training, things like that to keep them in shape while they're not able to climb, for sure.
So I also had a question. So if you're working with a climber in your clinic and you don't have climbing specific things like hang boards and stuff like that, do you think things like plate holds or like holds on like a chin up bar, like just backed off of the grip a little bit, like things like that, do you think those are specific enough to carry over into climbing? Or would you say that hanging from like an overhead position would be better?
I think you could make it work. I think hanging from an overhead position is going to be a little more specific, but you could have them hang from a pull-up bar with their fingers backed off, and sometimes that's enough for people. It's hard to get into that crimp position though on a pull-up bar. Like people tend to be more open-handed, and that can be fine, at least initially, just to get some kind of loading happening in their fingers. But like getting into that like crimp position is kind of important, because that's also going to put more stress on the pulley too, which we want. So you could have them do, sometimes what I'll have people do, I've had people do this, is like plate hangs. So like with a weight plate, a lot of weight plates will have like a metal lip or something like that. And you could literally have the client pick up one of those. If you can find like some sling or some webbing or some rope or like anything, something like this, where they can like hook their fingers in there and you can like load that, that could work. Or something you can even just like, if you think you're going to be seeing climbers, like get something like this is worth having in the clinic. Like even if someone can hang on a hangboard, like you can still load them with this in the clinic and it doesn't have to be overhead. Just something to get them loading their fingers.
Thank you.
Yeah, might have to get a little creative, but I think a lot of PT and rehab professionals are good at getting creative in the clinic. So.
All right, so we have a couple questions in the chat. One asked, would you recommend half crimp or open-handed dead hangs? I think you kind of were touching on that a little bit just now.
Yeah, I recommend the half crimp position, though some people can't tolerate it like early in rehab. So I think the open-handed position can be fine. But ideally like working them to the half crimp position, because that's the position that's been shown to put a decent amount of stress on the pulley, which we want for rehab.
All right. Next question is, what's the average percentage of progression per week regarding load or time in your experience?
Hard to say. I would say probably somewhere around like 5 or 10% is normal. If I had to say something like that.
And then Zach, if you'd like to go ahead and unmute and ask your question.
Yeah. Do you ever program any like isometric pulls or overcoming isometrics on the hangboard?
Sometimes I find that like people have a harder time with those because you really have to you have to have a crane scale to be able to do that rehab. And like, I'm not going through and doing like that stuff. I mean, I guess you don't have to have a crane scale, but you know, if you want to measure how much force you're putting through the hold, having a crane scale to do that, or some kind of device where you can measure that, and not everybody has that. So it makes it a little less accessible for people. Not everybody has a good way to set that up at home. But if it's something that people are familiar with and they want to do it that way, I think that can be fine. For regular hangboarding, it's nice because there's like we have the weight that you're hanging is the number that we can measure, you know, and you'll know, you know how much you're hanging. You can watch the progress over time. Whereas if you're doing the other way, then sometimes it's hard. Like, how hard are you actually, like, how much force are you actually putting through your fingers session to session? If you don't have a crane scale, it's hard to measure that. And it's hard to see the progress, if that makes sense.
Yeah.
So I think it's a fine way to rehab, especially if you have a way to measure it. I think it's a good way to do it, but it's just that most people don't have like a crane scale, so it's hard for them to see if they're progressing. It's hard to measure. It's hard to measure.
That's right. Okay.
All right, Dylan, if you'd like to go ahead and unmute, you can ask your question.
Yeah. So understanding like in terms of like the late stages of rehab and sort of reconditioning the pulley and maybe even like the tendons themselves, I know that like towards the end of climbs and things like that, you can really be, I don't know, pretty gassed. And like when you're reaching, you can kind of really like sink into a hold. And like there's a little bit of like a dynamic or sort of like impulse of like your finger like immediately like latching onto a hold. How, I guess, are you sort of like titrating that sort of aspect of it into like the rehab process? And like how might you be like almost like finger plyometrics, for like lack of a better term, you know?
Yeah, no, that's a good term for it. Yeah, so obviously that's not happening when you're doing just like regular hangboarding. So it's just an isometric, you're just hanging there. And that's not necessarily what's happening when you're climbing. So reintroducing climbing into somebody's rehab, like as part of rehab, is one way to do that. Like just having them start climbing again. Because it's going to happen when they're climbing, you know. And if we're doing it in a way that's like measurable and we're doing it at a rate that's tolerable for the person, then that sometimes that's all we need to do. Other times, people do need to do some kind of plyometric work for their fingers. And in that case, we can do it on a hangboard where we have them like, grab and re-grab. Or what I like to do is actually have them do some foot on campusing. So, and I don't think everybody here is a climber. So just so you know, like there's a tool called a campus board, which is really just basically like an overhung climbing wall that has like no bottom portion. And there are like rungs screwed into it of different sizes. They can be really big or really small. So it kind of almost looks like a ladder. And you can climb up that ladder without your feet. So you can hang like, kind of like Ninja Warrior style climb up it. And there's usually like a kicker at the bottom. So I like to have people do like foot on campusing so they can start on the bottom rung with their foot on the kicker. And we can have them do some like dynamic movements to, varying distances of varying like reps and sets depending on what we figure out that they need. That's my favorite way to do it because it's really easy to do that at the climbing gym. And there's a variety of rung sizes that we can use. So we can start on the big ones and ease them to like the smaller ones when they're ready for that.
Brad, thank you.
All right, we have another question in the chat. It says, how do you make progression and speed motion / plyometrics? Or isn't that essential when you make max / supermax loads?
How do you make progression and speed motion? So I think I sort of just answered that. Sometimes we don't have to get that like geeky with it. Like, oh, you're going this speed. Sometimes it's just about like getting somebody back into climbing, and that's going to happen anyway because that's part of the sport. Just getting back into climbing, they're going to be exposed to speedy movements and plyometrics that just happen normally in climbing. And so we may not have to do anything special outside of that. We may not have to measure anything special outside of that, unless somebody is having like very specific like discomfort that's lingering with a specific kind of plyometric move in climbing. And then maybe we would want to figure out a way to measure that or like at least mimic that as part of their rehab, which we can do on a campus board, or we can do by having them get on like a training board or like a spray wall or something like that. In general, I'm not like, I think to make like progressions in the plyometrics, like in other than like reps and sets and stuff like that, I'm not actually measuring speed or anything like that. Like you would have to have some kind of devices to measure to do velocity based training that way, and I just don't do that. I don't get that specific with it because I think just getting back to climbing is going to take care of that for the most part. Hopefully that makes sense.
All right, Chris, if you'd like to go ahead and unmute.
All right, I have two questions, and these are more like, I guess, big picture climbing related, and I don't climb, so maybe these are stupid, but like for you, I'm assuming, you have a broad range of clients that you see, either just like, rehab purely, or also coaching more of like performance side of climbing. How much does mechanics play a role, and how much are you like, changing their positions? And does it change, like, I know you're powerlifting as well, so I'm assuming you have powerlifting clients. Do you take a different approach from like, looking at a movement perspective, and how you kind of verbally say things or don't say things?
Like, am I cueing them to change their movement for climbing with regards to this kind of an injury?
For this kind of injury, or just in general? Like, do you kind of say, oh, well, maybe this is just the position that they're most comfortable in? Or are you like, well, this position is just going to be harder to hold it, so I'm going to tell them to change it?
Mm-hmm. Yeah, I will. So it's really different than like lifting, where like with lifting, obviously there's some variation in like, personal preference and like what makes good people, anthropometry, etc. We can teach someone how to squat to make them more efficient. With climbing, there's a little bit of that, but the positioning is like so variable. that it's hard to be like, okay, this is the way to do this move, because there's like 500 different moves you can do and like 500 different combinations of positions you can be in that move, because it really depends on the angle of the wall, the hold, how the hold is like tilted or not tilted, where your foot is, the angle of how the foot is turned, which is going to determine how you have to apply pressure to that foot. There's like so much going on. So it's not going to be the same as like lifting per se, but there are body positions or things like that that are going to help someone be more efficient, like where we're moving our center of gravity, what we're doing to like resist penduluming off the wall, how you're like, for example, like how you grab a hold and like where your shoulder is in space on that hold. Like you can't hold it like this, you have to catch it like this. So throwing your center of mass in a way that allows you to catch it like that so that you can hold the hold. Stuff like that, I guess, but not like form as in like form, because there's really no form in climbing. It's so variable. It's like there's no good form or bad form. There's just like positions where you're gonna be able to do this move, or positions where you're maybe not going to do that move because you're making it more mechanically like disadvantageous. So yeah, definitely, for sure, I'll keep someone on movement, and I'm always coaching people on like climbing technique and kind of understanding the principles of like how your body interacts with the wall and interacts with gravity. So in that way, yes, but not in like there's no real like form in climbing, if that makes sense. Yeah.
Yeah, that makes sense. And then the second follow-up was, is there like a culture or a belief with climbers that like they need to fix their or work on their like asymmetry because it's such a like gripping, pulling sport? Do they believe that like they need to, do these other things, or is that been ingrained in a lot of patients you've seen?
Yeah, very much so, which is like wild because it's such a variable sport and it is kind of an asymmetrical sport, and it's normal for people to have asymmetries. But yeah, I think that just comes from like cultural as well, and maybe they've talked to other healthcare providers that have like said that to them or whatever it may be. Yeah, a lot of people come in with that. They're like, oh, I've got this like hunchback, I've got this like climber posture, I need to like fix my thoracic mobility and like make sure that my serratus anterior is firing and like my shoulder blade is sitting a specific way. And actually we have research on this now that like that kyphotic posture is an adaptation to climbing. And so like, why would we want to train someone out of that position? It's actually an adaptation to the sport. So now we have like research that kind of shows that, a little bit of research. But yeah, I definitely encounter patients who come in with those ideas, or thinking that they've got some pain in their shoulder or wherever because of an imbalance, or even patients who come in and they think that because they have a pulley injury, they've got some kind of imbalance between their flexors and their extensors in their forearm, which is not really founded. So yeah, that's a big thing. That's a big one that I'm educating climbers on all the time, especially posture.
All right, Ethan, if you'd like to go ahead and unmute.
Yeah, so we've been talking a lot about rehabbing climbers from an injury, but in looking at getting especially someone who's maybe competitive back to like pushing their boundaries, obviously there's like a psychological component to that about whether or not they feel ready to do that, kind of like psycho-emotionally. But what are some markers that you look for that indicate to you that they're ready to start like going beyond their capacity again?
Yeah, I mean, if they're up to decent numbers on the hangboard, or if they have records of like old numbers that they've hit on the hangboard before, if they're getting pretty close to those, a lot of it is just going to be how their symptoms are feeling with climbing. And as we like reintroduce climbing, getting them closer to the grades or the styles of climbing that they were able to do before. And if we can be like, hey, look, you're climbing V7 crimps and you're not having like any finger pain, that's what you were doing before. So I think it's time to like transition you from rehab back into training again. Sometimes it's just about like having a conversation with them about what they're nervous about specifically, because sometimes they're like, yeah, I'm feeling really strong, my finger's not hurting, but I'm still really scared to like jump for that small hold and latch it. And if that's the case, then maybe we design some climbing drills for them where they specifically do that. And the nice thing about climbing is climbing gyms is we can do that. There's walls where we can have people do that. We can even change out the holds and make that hold a jug, like a big hold at first, and make it smaller, 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 so that they get comfortable jumping to a smaller hold. Things like that. So yeah, a lot of times it's about kind of figuring out, I mean, they're going to see their progress, they're going to feel their progress. So a lot of times it's like about finding out like what specifically are they nervous about doing, and can we design like a drill or something like that around that makes them feel more comfortable with it. Or is it just about educating them and talking to them about how the rehab process works and reassuring them that they are strong and capable of doing the things that they were doing before.
All right, so we have another question. Question asked, do you use turn-till burn? Says, I think it's a Swiss product. And then the follow-up was, if so, where do you see the advantages to a hangboard?
I don't know what that is. I don't know what turn till burn is. What is it, Marcus?
Oh, how I switched the music on. Can you hear me already?
I can hear you.
Okay, excellent. Actually, I think it was like many years ago, I was at an orthopedic congress, and there was like a climber, medical healthcare specialist, and he was a very good climber, and he presented this turn till burn, and it's actually only a bar hanging, which is turning when you.
Oh, I know what you're talking about.
Okay, and actually, it was regarding that pulley injury, and yeah, he was presenting that. So I was wondering what you think about it.
Yeah, if it's the one I'm thinking of, yeah, it's the pull-up bar that like turns. Maybe you could, I don't use it. Maybe you could use it for rehab. It's not going to be that specific to the pulley itself, because that kind of grip, it probably does stress the pulley like a little tiny bit, but the half crimp is really going to be a lot more specific.
Yeah, I think his idea was like to open the hand when you go down, and you try to hold it as long as possible without losing, and yeah, roll up.
Or to do an eccentric, yeah. Yeah, I guess you could use that. That's something that might work better for like a flexor tendon injury.
Yeah,
that's something that I definitely do. I'll have people do like finger curl eccentrics and stuff like that. Yeah.
Okay, thanks a lot.
All right, so we're going to finish off with these last two questions. So the first one is from Zach. It says, are there any specific climbing resources you recommend?
Climbing resources. Climbing resources in terms of like injuries and rehab and stuff like that, I guess?
Yeah, like more related to like rehab and like what we're talking about now.
I'm going to be honest, there's not a lot of good resources out there. There's one book called One Move Too Many by Volker Schaffel, who does a lot of the climbing injury research. So I think looking at that book could be helpful. He does go through a bunch of these different climbing injuries and discusses like what they look like, and photos of things, and tests you can do, or the specific anatomy of these injuries, and that stuff can be good to know. But in terms of like what's recommended as rehab and and stuff like that, I don't really like the book for that, because a lot of it is like, oh, like here's a way you can tape it, or like here's a way you can immobilize it, or here you should ice it, which I'm not going to do any of that stuff. So I don't think it's a good resource for like rehab. He's an orthopedic surgeon, so he's not like a physical therapist or somebody who actually does rehab. But he has good information on these injuries, and so it's good to know that stuff, and like getting familiar with some of his research is good too. So I would look at that stuff. In terms of like one good source of information for rehab, I don't know. I don't think there's like a lot of really good resources. Yeah, you can look at my stuff. I don't have it all in one place though. I don't really create content with rehab professionals in mind. It's more for clients, but yeah. I like Tyler Nelson's stuff, if you know him, Camp for Human Performance. He's doing some good stuff. He's doing a lot of like extrapolating from other sports and using science from those sports to apply it to climbing training, which I think is interesting. But he's got some good information as well. Yeah. Jared Viggy, Esther Smith, Carrie Cooper. Yeah, Carrie's cool. Esther Smith has a good loading protocol for climbers as well. Yeah, that I would recommend.
Thank you.
All right, we have a question from Max. It says, are you manipulating wall angle / climbing style early on as a part of your process to reintroduce climbing?
Yes, it can be hard to do. So it depends on what the client has access to. Like sometimes people are like, oh, I just have a home wall that's set at 40 degrees, which is what I have at home. It's a 40-degree wall. I can't change it. But I can we can modify like what kind of holds people are climbing on. We can, if they're at a climbing gym where they can do this, they can change the terrain. They can choose a different style of climbing because they've got a lot of different climbing accessible to them. We could even take someone from bouldering, which is like harder climbing on shorter walls, and have them do some sport climbing for a while, because that's longer climbing. Ropes are involved and stuff like that, but because of the nature of the climbing, it's longer, it's less intense. They're going to be able to get more climbing in without it being as intense as bouldering. So sometimes I'll just recommend that they switch over to sport climbing for a period of time. So we can do stuff like that for sure. Some gyms will have like an adjustable wall, which is cool because we can, have them start at like a pretty low angle and we can make it steeper over time. So yeah.
All right, and then the last question is from Cody. It says, for the climber whose entry point for rehab is something like 1 to 2 kilograms hanging off the finger block, parentheses higher ability, do you have some threshold for progression with hangboard performance and tolerance when you reintroduce low-level climbing?
For the climber, I'm reading his question again. For the climber whose entry points 1 to 2, do you have some threshold for progression and tolerance where you reintroduce low level climbing? Yeah, I mean, a lot of times, because like climbing is so variable, like even if they have a really sensitive finger, like we can have them like try. Sometimes we don't know until we have them try. So I'll be like, do you want to climb? And sometimes they're like, no, I just want to like do the rehab, let my finger chill. They're like nervous. They don't have to climb if they don't want to, but I try to get them to climb. So especially if they're interested in climbing again, then okay, what I want you to do is like, after you do the rehab, like go to the gym and like, let's just get you on something really, really easy, vertical or less than vertical. So like not steep, but like going like from a vertical wall to like almost like you're walking uphill angle. And we can have them get on something really easy at that angle, because if it's vertical or less than vertical, they can keep most of the weight in their feet actually. And so it tends to be less irritable for these finger injuries. So a lot of it is just like having them go in and try climbing and see what they can tolerate. And have them work up to like an intensity that they can tolerate. And then that's where we would like start them, and then just kind of progress from there, like while we're also doing like the finger rehab on top of it. Does that answer your question?
Awesome. Okay. So to wrap things up, Natasha, is there anything else that you kind of want to conclude as your final message?
You'll notice I left out anything that's not loading. I think a lot of climbers have been told to ice, massage, this and that, tape it. I don't think any of that stuff is necessary for these injuries. Like, it's really just about finding an entry point and then loading them and progressing from there, and then trying to get them back into climbing as tolerated. And it can be like a tricky path to navigate. So I always just let people know ahead of time, like, hey, this is not as cut and dry as being like, go into the gym and just stay on everything that's under V3. Cause like you could get on easy climbs for the person that irritate the finger, whereas like you can get on a hard climb for that person that doesn't irritate the finger. So it's about finding the path for them. Yeah. Hopefully that was interesting to everybody. It sounds like some people here climb, so that was probably fun to hear about. For other people here, they don't climb, but hopefully it was still like interesting, and maybe you'll see a climbing client and you'll be able to apply this information. And if you are stuck or you're not sure, you're always welcome to like message me and I can help you with your client.
That's awesome. I mean, from all of the feedback and stuff that we've even gotten in the messages, it's been absolutely fantastic. So we appreciate you so much for being here. And again, if you just want to tell us like your Instagram handle and your website and stuff like that of where people can find you, that'd be great.
Yay, thanks for having me. Yeah, you can find me at Natasha Barnes on Instagram. That's where I'm at most of the time, not on Facebook. I mean, I am on Facebook, but if you message me in there, I probably won't see it for like 8 weeks. Yeah, you can find me there, or my website, natashabarnesrehab.com, but Instagram's a pretty reliable way to get a hold of me. And if you guys want to shoot me a DM or whatever, go for it.
Perfect. Awesome. So before you guys leave, I know we've lost probably half of our people already, but I'm going to put a survey in the chat if you guys want to let us know how much you liked this, if there's anything we can do to improve it. There it is. Also, I want to, I know about half of our people that came today have never come to a CALU event before, which is so cool. We do these on like a every other month kind of basis. And then we have a lot of other events and networking opportunities and things for people in if you're a student or a clinician in the rehab type of field. So I'm going to put the Facebook group here. If you guys want to join, we'd love to have you on there. We have tons of people with great conversations and everything there as well. I just want to thank you so much, Natasha. Again, I remember when I was first kind of like really frustrated when I was in school, I was trying to find other resources of people that would give me hope for continuing in the profession. And I found Clinical Athlete and I found you right around the same time. And I've looked up to you ever since. So it was an honor to kind of have you on here and lead you through this. And it was awesome. I know in chiropractic school for me, it was frustrating because a lot of things were heat, soft tissue adjust. And that's kind of and like pounded into your brain the whole time, even with clinicians, overseeing clinicians and things like that. So what you're doing and the things that you're providing for your clients and climbers specifically is just so great and refreshing to see it, a whole different avenue of chiropractic kind of coming out in the way that you can do that. So I really appreciate all of you guys. And then again, thank you to the Clinical Athlete team, the Level Up team, especially to Derek for coming through, helping us with all the behind the scenes stuff, timing and Q&A stuff. So it's been awesome. And I appreciate everybody for coming. So thank you guys so much. And we'll see you at the next one.
Thanks for having me.